Recording. All right. So again, welcome everybody. We may have some folks still trickling in as we move forward, but just for the sake of time, we will go ahead and get started. So today's discussion will be on hepatitis C treatment and case management. This will be presented by TDH's registered nurse, Amy Baker. And then also we do have two case presentations today, and then we will have an opportunity for Q&A. I do just want to make a note about today's case presentation that, of course, this is TDH's process. We did try to make it to where it's not necessarily role specific, but can definitely be applied across, facilities or clinics. As always, if you have not registered through the Southeast AIDS Education and Training Center to receive the continuing education credit for participation, please do so. You can join by creating a profile on their website, and then you will use the QR code for today's session or the direct link, and you can register. There will be a post-survey emailed to you, and then manual attendance will be reviewed, and then once that process is complete, they will then email you your certificate. Kimber has been so gracious to drop the link information in the chat. So again, if you've not done so and you are interested in receiving that continuing education credit, please ensure that you have your profile created on SEAETC's website and you go ahead and you register. So just a few introductions and announcements. If this is your first ECHO session, please feel free to drop your name in the chat. Please include your role and the facility in which you're affiliated. We do like to welcome new members. And also, if you do have any technical issues with today's session, please feel free to reach out to Kimber Miller. She did drop her information in the chat. And she's also wanting to wish everyone a safe and joyful Independence Day. And it looks like for today's SMEs, what we have right now, we have Dr. Allen who has joined us, and then we also have Dr. Chastain who has joined us. Oh, great. We have welcome, Sarah. We have a second year Meds Peds resident from Vanderbilt. And we have Bethany and Jessica Moore with the local health department. Welcome. All right, we'll go ahead with next slide, please. So as I mentioned, if you have joined, today's session will be on hepatitis C treatment and case management. This will be presented by Tennessee Department of Health's Annie Baker. She is our registered nurse, and she is our acting hepatitis C treatment coordinator. Annie, I'm going to go ahead and turn it over to you.
Okay, thank you, Lindsay. Okay, so we're going to be discussing case management with hepatitis C treatment. Disclosures, there's nothing to disclose. Objectives, by the end of the session, participants will be able to identify case management practices throughout hepatitis C treatment. The first step in this process, treatment initiation. This begins with the provider intake. So patients are seen by a provider via in-person clinic visit or telehealth platform. Some of our health departments do not have a primary care clinic, so an alternative option is to see patients in specialty clinics, as these are offered at every location. So these could be STI or family planning clinics. During the intake, the provider discusses treatment options, patient's readiness for treatment, and reviews laboratory results. Pre-treatment labs may be collected at this visit if not previously obtained prior to visit. Pre-treatment labs may have been collected per the public health nursing protocol if we have a hepatitis C RNA documented. Pre-treatment lab collection is encouraged to prevent patient from returning to clinic for multiple visits. For uninsured patients, the provider completes the patient assistance program application and submits to the drug manufacturer. Patients are encouraged to bring appropriate documentation to the appointment. These documents can include proof of income or letter of support, the spouse's proof of income if married, attestation letters, etc. The clinic then notifies the treatment coordinator or appointed contact of the patient's treatment initiation. Through TDH, we offer a centralized case management option to regions where through the state, which directly involves the treatment coordinator. The treatment coordinator provides case management to multiple patients throughout their duration of treatment across multiple regions throughout the state. If a region opts to case manage their patients regionally or locally, then a point of contact is typically appointed to handle patients' paperwork and follow up throughout their treatment. For insured patients, there is a prescription that needs to be signed and forwarded to the treatment coordinator or the appointed contact. And again, this point of contact is notified that the patient has begun the treatment process. At the provider visit, it's important to offer some patient education. The provider informs the patient the hepatitis C treatment coordinator will be in touch with them to discuss the medication delivery and treatment follow-up. It's important to emphasize that medication will not be delivered until the patient has arranged for the shipment with the pharmacy, whether through the drug manufacturer or a specialty pharmacy. We should also encourage communication with the hepatitis C treatment coordinator regarding medication receipt and start date, and provide the patient with a patient education handout to outline the expected process. This is the patient handout we use in TDH. It outlines the expected process and contains hepatitis coordinator's contact information. This handout has proven to be very helpful in keeping patients engaged by knowing when to expect a phone call and what number to watch for. Patients are also informed of the ability to text the treatment coordinator for any questions or concerns related to treatment. Now, this is where the case management begins. The hepatitis treatment coordinator is notified that all intake and screening measures have been completed and patient is ready for treatment. Our health departments utilize a system called REDCap, which is also used for tracking data. For uninsured patients, the coordinator will communicate with the drug manufacturer to assist in patient approval through the patient assistance program. For insured patients, the coordinator completes insurance-specific prior authorization forms via Cover My Meds online and submits chart records. Once approved, prescription is then sent to a specialty pharmacy. If a provider agreement is in place, we also have the option to forward chart and prescription to a specialty pharmacy who will fill in all required information on the PA form and then return for provider or designee to send a plan. When approval notice is received, the treatment coordinator contacts the patient to inform of approval and discuss delivery of medication. Patients do have the option to have medication delivered to their home or to the provider's office. We do often, not often, but sometimes encounter some insurance challenges. So I will check the insurance formularies to notify a provider if they have selected a medication that is not listed. Another one, insurance may require a genotype. So I will first attempt to submit a letter stating that the patient qualifies for simplified treatment with pangenotypic medications per the AASLD. I've had some success with submitting this letter, but if the insurance insists on the genotype, then the provider is notified that additional lab is needed. We do have a few insurances continuing to require a drug and alcohol toxicology report. Again, I will first attempt to send the appeal letter citing the recommendations. When there is a high copay, some of our specialty pharmacies will assist the patient with applying for a copay assistance through the manufacturer. If the pharmacy doesn't do this, then I'll assist the patient with doing so. If the copay is beyond the assistance maximum, then I or the pharmacy can provide the patient with alternative assistance through hepatitis C foundations. Some insurances will require a consultation with a specialist or documentation that a specialist may be consulted if needed. A letter documenting access to specialists through Project ECHO is often accepted. Patients are instructed to notify the treatment coordinator when they receive their medication and begin treatment. The treatment coordinator will review prescription instructions, how to take the medication, and to expect a follow-up at 2 weeks. Patients may contact treatment coordinator with any side effects, questions, or other concerns. And then again at 2 weeks, the treatment coordinator contacts patient to discuss side effects, encourages treatment adherence, and reiterate hepatitis C education. During this follow-up, patients are encouraged to schedule a refill if not already done so. Patients are also given instructions to change out personal hygiene items such as razors, toothbrush, fingernail clippers once they complete week 4 of treatment. They are also reminded to notify treatment coordinator of treatment completion, and the provider is notified of each of these steps via charting in the patient's electronic health record. Continued follow-up, the treatment coordinator follows up nearing end of treatment to ensure completion and discusses with the patient the test of cure date. Reinfection prevention education is also provided. Patients then contacted when the SVR12 is due to remind them to schedule a lab appointment. Throughout the treatment process, the treatment coordinator is a resource to the patient and provides any necessary follow-up as needed. And all contact attempts and communication with patient and pharmacies is documented in the electronic medical record with the prescribing provider tagged. And I talk really fast, but that's it if there's any questions.
And I know we've had several folks join since we started this session, but I do want to highlight that Annie is a nurse with the Tennessee Department of Health, so she is one of our own. But we did adapt this presentation to where it could be applied to multiple facilities. If you are interested in, hepatitis C treatment, or maybe you have been treating already, but you're kind of struggling with that case management process and that follow-up, as we know that sometimes reaching out to patients can be difficult and getting them to actually follow through with reaching out to someone to confirm their start date or to confirm that they've got their refill or to confirm that they've completed treatment. And so this can definitely be a great resource. I will also say too, and Annie can piggyback off this. One thing that we personally have found that has been very successful is the patient builds a relationship with, in this particular situation, Annie or an appointed contact. And we think that that really goes far with the patient because they're able to, pick up the phone and call and directly talk to someone. They're able to text, if there's an issue. And then that way the patient feels like, someone is really directly involved in their care and, cares and is knowledgeable about their treatment. Would anyone like to come off mute and that's maybe outside of Tennessee Department of Health and talk about their process?
I think one thing I'll just say is working with a lot of different groups is that the process as far as pursuing and getting medications approved is often best fit to the context based on the personnel that's available to you. This is not does not have to be a provider centric process. It can be a team based centric, and that sometimes is a nurse, sometimes that's a case manager, sometimes that is actually a patient navigator of some type within a clinical setting. Sometimes that might be a pharmacist, and actually sometimes can be beyond the scope of your individual practice. A good example of this is collaborating with a specialty pharmacy, a specialty pharmacy that actually can help facilitate a lot of different steps beyond the collection of data. I think that Annie did a great job as far as summarizing some of the data collection and putting things together. But sometimes once that data is collected, actually partnering externally with a specialty pharmacist can actually be quite helpful. And that doesn't necessarily mean you have to have a pharmacist on your own staff. It means developing a relationship with a place that you're going to submit that material through and have a consistent point of contact. That's not a one size that fits all because you might have a group of clients or patients to have a variety of payers. And so sometimes you might need to work through patient assistance programs, sometimes that you need to work through uh, specific formularies. But the flip side is that a lot of specialty pharmacies and tools might help initiate the process, and they might find after working with or collaborating with a group that they aren't able to fill, but they can often help facilitate the transfer of that. So developing that relationship can be often a real great way to expand your capacity without relying on your existing staff.
I agree with that, Dr. Chastain, and I will say that um, we, as the Department of Health, did not start treating patients who had insurance until the last year, year and a half. And I firmly believe building those relationships with those specialty pharmacies, that has helped us tremendously, being able to navigate that process. As we all know, that insurance can be a bear sometimes to navigate, and there's so much to be learned, and they have been really, really helpful with us as well. Dr. Allen, I think you're on the call today. Do you want to elaborate a little bit on how, from the pharmacy side, how you kind of help facilitate this in your clinic?
Yeah, so my situation is, of course, unique where I, as the pharmacist, actually go see the patients in clinic as well. So the physician will see them, make sure they're deemed for treatment, and then I'll go in and start my process. So I do have a dual role of seeing the patient in the clinic, but also working with the specialty pharmacy here at Regional One Health. Is that ideal? It is for me, and I know that's not ideal for everyone, but I do want to explain kind of what I do to kind of streamline the process for our patients. So I will interview them, check on their demographics, check on their medications, make sure their insurance is active or what is active, look at formularies, and then of course if they don't have insurance, we'll look at the patient assistance for the medications that is preferred based on lab work and all the other things that we look at for hepatitis C treatment. So once we've decided on a medication or medication course, I'll either submit a prior authorization or submit patient assistance. So it's going to be a fax or electronic application either way. And then once that information comes back, we'll focus more on insurance side of it first because there is more challenges, as Annie suggested, that there can be copay issues, there can be extra lab, there can be toxicology questions that you need to make sure you hurdle those barriers to meet the needs of the insurance, but also meeting the needs of the patient. So we want to make sure we're playing by the rules and making sure we're doing all the steps that they require within reason, of course. And of course, we can do appeal letters as well. Now, once we've got the insurance to approve it, then the challenge is not necessarily always over because copays do come into play with these medications. Even the generic versions of the hepatitis C medications, they can still be several $1,000s. There are copay cards available for the generics of the hepatitis C medication. So that's the main thing, that if you're new to the space, just because the insurance doesn't require a brand name agent, either trade name Epclusa, trade name Harvoni, or trade name Mavyret, the generics of Harvoni and Epclusa, ladipizir, sofosbuvir, and sofosbuvir patazir, they do have authorized generic copay cards available through Asegua Therapeutics on their website. That's very unique to this space. Usually, if a medication has a generic, there's not a copay card available, but there are assistance programs for the copay cards for those two medications. There is a max of only about, based on my experience, of $6,000 on the card, but that usually will take care of the copay that is required, whether it be a large deductible or getting them to max out of pocket. Those type of things are the challenges that can be in play once we start the medicine, because I try to make sure on the front end that we're going to make sure we are able to get the entire course paid for fully without there being some run in on the last feel of it running out of copay assistance, because that's what I want to avoid, because I want to avoid incomplete treatments, or yeah, if they got 2 months of it, we would maybe deem them treatment failure if they saw more than the 28 days. If we're going to look at the guidelines, if they got more than 28 days of medicine, we would probably deem them treatment failure. So I don't want to set them up for failure. I want to make sure I do investigations on the front end before I get to that point. That way it's a smooth, seamless process for the patient. They, of course, don't know that I'm doing all this in the background to make sure it's a seamless process. So, of course, it seems easy to them. But for me, I want to make sure those things are set up to be prosperous and advantageous for the patient to get through treatment quickly and as small speed bumps as possible. So I would say those are the main two things. One, making sure we meet all the requirements for insurance, and then of course making sure we address copays on the front end. And that goes back to what Dr. Chastain said about collaborating. If you don't have a pharmacist on staff, getting in touch with a specialty pharmacy in the area or one that you want to work with and have all of your prescriptions going to the same place. That way you can develop that rapport with them and they can help you out understanding about the copays or the deductibles or whatever the patient might be seeing from an insurance standpoint to make sure that they're getting the medication course fully. And so I tell my patients in my clinic that our main goal, if they're on a commercial plan and they have copay card availability, that they should only be paying $5 for each fill. And that's always my goal. And it's very, very rare that that's not able to happen. So that's what I tell them on the front end, and I want to make sure that does happen. And of course, as Lindsay said, we may need to look at other foundations if that's not the case to see if there's other financial assistance out there that can help us get to that goal of being $5 per fill. Does that kind of answer your question, Lindsay?
It did. Thank you.
Yep.
It's nice to see